for MH, who's a legal guardian for EH, who is a patient here at Western State Hospital. Today's date is Monday, June 21st, 2021. Location is we are teleconferencing, but I'm at Western State Hospital. I would like to move on to introductions of the LHRC parties and all the representatives. So what I would like to do, because there is a lot of folks here in the room, I would like to start with the LHRC. And once the LHRC identifies themselves, then move on to the members of the DLCV. Okay. LHRC, Ms. Hall, would you like to start?
I'm Renee Hall. I'm the chair for LHRC, Western State Hospital and Commonwealth Center.
Teresa Bouthillier, vice chair.
Doug Cochran, member of LHRC.
David Paulk, member of LHRC.
Okay, that's all the LHRC members. DLCV, who would like to start?
I can start. I'm Virginia Ferris. I am a senior advocate with the Disability Law Center of Virginia, and I'm going to be representing the client today.
Okay, thank you.
I'm Becca Herbig. I am a staff attorney with the Disability Law Center of Virginia.
Thank you, ma'am.
I'm Rhonda Thyssen. I'm also a senior advocate at the Disability Law Center of Virginia.
Thank you, Ms. Thyssen. And I believe there are some interns.
Good morning, sir. Erin Pettigrew, legal intern at DLCV.
Okay. Anyone else from DLCV?
Yes, Carolyn Stow, also a legal intern.
Okay, thank you, ma'am.
And then Shelby Fuchs, I'm a legal intern as well.
Okay. And that completes DLCV. Ms. Huber, Ms. Marion Huber.
Yes, I am the sister and guardian of the person this complaint is about, and her name is Elizabeth.
Yes, ma'am. Thank you. And I am Maynard Ritchie, human rights advocate at Western State Hospital, and I will be the technical advisor for the LHRC. And also from DVHDS, Office of Human Rights. Who else do we have?
Hi, this is Brandon Rotenberry. I am the Facility Advocate Manager.
Good morning. This is Carlton Henderson, Training and Development Coordinator for the Office of Human Rights.
Okay. And does that complete everybody with, is there anybody that has not identified themselves or introduced themselves yet?
I believe the Western State members.
Oh, I'm sorry. Western State members, could you identify yourself, please?
John Anderson, Facility Director, Medical Director, Western State.
Okay.
Gail Burford, Director's Representative to the LHRC. Nadine Robotham, Director of Nursing.
Jessica Clark, Psychiatric Nurse Practitioner.
Dr. Aaron, Clinical Psychologist.
I'm sorry, the last name was what, Doc?
Dr. Gallagher.
Gallagher. Yes, ma'am. Okay. Anyone else from Western State Hospital? Okay. So there are no further introductions to be made. We will move right along. The next portion will be the review of the rights of the parties. Each party to the hearing has a right to a reasonable notice of the hearing, which we were given, a speedy and impartial review, an appearance in person and or by a representative at the hearing. They have a right to be heard, present facts and proof, including witnesses and documents, a prompt decision after this hearing, an explanation of the basis of the decision, and an appeal adverse decision to the LHRC, to the State Human Rights Committee, SHRC. So everyone has, either side has a right to appeal the decision if they disagree with it after the LHRC. A review of the client's additional rights is a client has a right to access information processed by Western State Hospital unless such information is restricted from disclosure. An open hearing upon request. To DLCV or to Ms. Huber, do you request an open or a closed hearing?
Open.
Open?
Yes, sir.
Okay. They also have a additional right to confidentiality and freedom from retaliation. Review of the rights of the client for an open or closed hearing. You have a right to an open hearing where all information discussed about you is available to the public and anyone can be present during the hearing. So since you've elected for an open hearing, if you were going to go with a closed hearing where all the matters are confidential and only the people sitting around the table in this meeting can be present. So you've elected for an open meeting.
Correct.
Yes, ma'am.
Correct.
Okay, since the petitioner has chose for an open hearing, the chairperson needs to read the statement below. And you don't have it, do you, Renee?
I don't. Would you please read it for me, Maynard?
Yes. May it be noted for the record that the Western State Local Human Rights Committee is concerned with the preservation of client privacy and confidentiality of medical records. For this reason, we wish to assure at this time that the right to a closed hearing pursuant to the Code of Virginia 2.2-3711A15, paragraph 15, has been thoroughly reviewed with the complainant on behalf of the subject record. MH is authorizing the disclosure of information that would be exempt from public dissemination. So that's the statement. And basically what it says is that the petitioner is authorizing the disclosure of information that would be exempt if it was a closed hearing.
Correct.
Okay. Okay, the explanation of the procedures of the hearing. MH will present evidence and testimony. First followed by Western State Hospital. Each party will have up to 5 minutes for an opening statement, 15 minutes to present pertinent issues, and another 5 minutes for closing statements. The 15-minute presentation of issues may include witness testimony. In keeping with guidance from the State Human Rights Committee, the Staunton area, LHRC, will not entertain cross-examine of witnesses by the other party. The LHRC may ask questions of either of the parties and their respective witnesses. The LHRC will go into executive closed session for deliberation and intend to deliver a summary of findings within 10 working days following this hearing, which would be July the 5th, 2021. Either party maintains the right to appeal an adverse decision to the State Human Rights Committee. A request for a fact-finding hearing was filed by Maynard Ritchie, human rights advocate, on behalf of MH, the legal guardian of EH, who's a patient here at Western State Hospital. The petition being heard by the committee today alleges violations of the human rights regulations. At this time, the committee will begin the hearing. MH, Ms. Huber, do you or your designee wish to use the allotted 5 minutes to make an opening statement?
Yes, we would.
Okay. Go ahead and begin, please.
Okay. Thank you to the members of the LHRC for taking time to hear about Elizabeth Huber. Elizabeth is a 60-year-old woman living with mental illness and a developmental disability. She has an extensive history of trauma and suffers from arthritis so severe that she needs to use a rollator. On December 2nd, 2020, she was admitted to Western State Hospital for psychiatric treatment. At the time of the incident in question, she was residing on the 2 Oak unit. Due to the severity of her health conditions and chronic pain, she was later moved to the more medically intensive Dogwood unit. She has since been discharged. On December 9th, it was clear that Elizabeth was having a bad day. Her sister, Marion, who is Elizabeth's guardian, explained that Elizabeth had a dental appointment that morning and that such appointments often make Elizabeth nervous and upset. Throughout that day, Elizabeth yelled, banged her hands on the table, and was reported as verbally aggressive, disruptive, and not redirectable. At 4:45 p.m., unit staff placed Ms. Huber in the seclusion room, quote, due to disruptive behavior and upsetting peers. Because of her severe arthritis, Elizabeth wasn't able to stand independently, nor was she able to sit on the mattress on the floor. Rather than providing her a chair, Western State had her sit on the seat of her walker for over an hour. Ironically, according to Marion, staff did allow Elizabeth to use a chair as a makeshift table while in seclusion so she could have her meal. She wasn't released from seclusion until 6 p.m. after being determined calm and cooperative. The next day, Elizabeth talked to her sister Marion and told her that staff had put her, quote, in a room with a key. This raised alarm bells for her sister, who called a nurse and was eventually put in contact with Elizabeth's treatment team. They had not proactively told her about this episode. Then she learned that Elizabeth had been put in the seclusion room for what was essentially yelling, and that she was not given a chair while she was in the seclusion room. While Elizabeth may have had her rollator with a seat, this seat is not intended for use over a long period of time. The seat is too small for her frame, provides no back support, and doesn't really have padding, so it would be uncomfortable to sit in for an hour plus. According to Marion, Elizabeth frequently refuses to sit on her rollator because it is too uncomfortable and she does not feel secure on it, even for short periods of time. Marion filed an abuse complaint with the human rights advocate, Maynard Ritchie, who relayed this complaint to former director Dr. Mary Claire Smith. As Western State has already acknowledged in their response to our petition, almost everything that followed was done incorrectly. They failed to open the complaint properly in their system and failed to even attempt to notify the guardian of their findings for over 2 months, and failed to actually deliver findings to the guardian until April, 4 months after the complaint was filed and well outside the 10-day window. Western State failed Elizabeth in nearly every aspect of this event. Western State failed through the improper use of seclusion and restraint. Western State failed to conduct a full and proper investigation. Western State failed to follow sound therapeutic practice. Western State failed to protect Elizabeth from abuse and neglect. And all of these failures are violations of Elizabeth's human rights. Thank you.
Okay. Western State Hospital, do you wish to use your 5 minutes allotted time to make your opening statement?
Yes, please.
Okay, your time begins now, ma'am.
Chris complaint number 202-00245 was logged on 12/10/20 as a result of a complaint by the guardian of number 1 with regard to a 12/9/20 alleged use of seclusion, citing that it was not therapeutic. Further, the complaint describes concerns regarding the use of Haldol medication. The facility patient relations coordinator investigated the incident, finding that treatment team members, primary care, clinical psychologist, and attending psychiatric nurse practitioner had been in direct telephone contact with the guardian on 12/10/20. Interviews with these team members indicated that the concerns of the guardian had been satisfactorily addressed. The team documented in the medical record that they had engaged in a 43-minute conversation with the guardian. Please see Exhibits 2 and 3 from Western. The conversation included discussion of the incident in question and medication. Western State acknowledges a process error after the resolution described above. The documentation of the investigation was incomplete, and a letter was not generated to individual one's guardian within 10 working days. After the advocate was contacted by the guardian on February 11th and the director's office alerted, within 10 days, a facility response letter was generated. That's Western State Exhibit number 4. In April 2021, the facility was informed by a telephone by Ms. Huber that she had not received the February letter from the director. Upon this notification, the February letter was resent via certified mail, which DLCV reported was received by the guardian on April 19th. Subsequently, on 4/21, an email correspondence from DLCV informed the facility of the guardian's intent, pending a request for additional information, to appeal the director's findings as described in the letter. A petition for hearing followed on May 11th. Western State requested and was granted a response extension. With regard to the event in question, the individual was relocated to a more private area on the unit in a continuing effort to de-escalate her behavior. At no time was the client secluded or restrained. The petition mischaracterizes a successful behavioral remediation as a seclusion event. Western State's hearing response will address the alleged violations individually. Thank you.
Maynard, you're muted.
Oops, sorry about that. Okay. Thank you very much, Western State Hospital. Ms. Huber, would you or your designee like to take 15 minutes allotted time to present your case?
Yes, we would.
Okay. Your time begins now.
First, we will be discussing the inappropriate use of seclusion, but in order to do so, we must clearly define definitively that this was seclusion. In their response to our petition, Western State stated repeatedly that they could not have subjected Elizabeth to inappropriate seclusion, as this wasn't seclusion, but open seclusion. They insisted that because the door was not closed and locked, that this very clear use of seclusion didn't count as actual seclusion. This is a complete misreading and misunderstanding of the regulations. The regulations define seclusion as the involuntary placement of an individual alone in an area secured by a door that is locked or held shut by a staff person, or by physically blocking the door, or by any other physical or verbal means so that the individual cannot leave it. Simply put, it does not matter that the door was open or unlocked. If staff told her that she couldn't leave the room, it's seclusion. If staff blocked the door, it's seclusion. The records consistently describe Elizabeth as being placed in the seclusion room by staff due to disruptive behavior and released when staff found her to be calm and cooperative. The only way Elizabeth would have been released is because she had staff's permission, meaning that she could not leave the seclusion room by her own choice. Furthermore, Elizabeth herself characterized the event as one in which staff put her in a room with a key when describing it to her sister the next day. By attempting to create a new category of seclusion, Western State is trying to make a loophole in the regulations. If they seclude people but don't call it seclusion, they can bypass all protections provided by the human rights regulations. Such an interpretation gives hospitals a very dangerous leeway where they can effectively seclude people but not have to follow the guidelines that are in place to protect patients. Despite Western State's assertions to the contrary, their actions do meet the definition of seclusion as defined in the regulations. Furthermore, several key documents, including the findings letter sent by Director Smith regarding the complaint, call this incident what it was, seclusion. Therefore, this use of seclusion is what it has always been, a use of seclusion. Since this episode was clearly and definitively an episode of seclusion, we can now discuss Western State's improper use of seclusion. As I said during my introduction, Elizabeth was having a bad day on December 9th. It's common for her to have behavioral episodes when she is in pain or when she is in medical settings. By all accounts, Elizabeth was yelling a lot that day and insulting staff. However, the regulations are clear that seclusion can only be used when necessary to protect the individual or others from harm, injury, or death. Western State's own seclusion restraint policy states that the only time a patient can be placed in seclusion is in emergency situations when necessary to prevent the patient from physically harming self or others. At no time was Elizabeth at imminent risk of harming herself or others. Yelling is not harm. Being disruptive is not harm. In their response, Western State attempts to qualify this risk when Elizabeth approached staff as if she was going to hit early that day. But this isn't the point at which they placed her in seclusion. That happened hours after, an entire shift after even. Western State admits very openly that the entire reason that Elizabeth was placed in seclusion was due to disruptive behavior and upsetting peers, and not being redirectable. None of this meets the standards laid out in the regulations. Western State also attempts to justify violating Elizabeth's rights by explaining that her being non-redirectable could have been a precursor to pending aggression, and claim that the effect of constant disruption on the safety of the milieu cannot be overstated. This attempt to categorize disruptive behavior as an immediate safety threat creates a universal justification that any behavior staff considers troublesome or disruptive can be labeled as unsafe. It is clear that Western State believes that if a patient is disobedient, then that justifies the use of seclusion and restraint, which speaks volumes about the facility's attitudes and commitment to trauma-informed care. It's clear that the use of seclusion was initiated not because Elizabeth was at imminent risk of harm to herself or others, but to combat disruptive behavior in disturbing the milieu, which was essentially for the convenience of staff. Furthermore, staff's defense of seclusion by calling Elizabeth non-redirectable highlights that obedience was their aim rather than safety. Using seclusion as punishment for disruptive behavior and to make staff's ability to manage the milieu more convenient is a clear violation of the regulations. Regulations not only define proper use of seclusion and restraint, they also state clear documentation requirements. One of a provider's duties is to document all known contraindications of the use of seclusion or restraint, including medical contraindications and a history of trauma. On their seclusion restraint contraindication form, Western State made a single notation under contraindications: none. This ignores the entirety of Elizabeth's trauma history, the years of provider neglect, abandonment, and abuse, nor any of her medical conditions and chronic pain. Western State attempts to sidestep this responsibility by pointing out that this history is elsewhere in the services record. However, this does not negate Western State's responsibility, per the regulations, to document these conditions as contraindications to the use of seclusion restraint. Western State felt strongly that it was not DLCV's place to comment on this evaluation because it was a clinical consideration. I want to be clear. This is not about whether the use of seclusion was necessary despite the contraindications listed. This is about how Elizabeth's medical conditions or trauma history were not considered as contraindications. As for the rest of the documentation required by the regulations, there's no evidence that the records provided by Western State that they completed any of the appropriate documentation related to an incident of seclusion. Since we, and more importantly, Western State's director at the time, in her findings letter, categorized this incident as seclusion, the regulations require that it should have been documented as such. Western State failed to keep Elizabeth free from unnecessary seclusion. Proper use of seclusion is a violation of the human rights and violation of her rights. Next, we will discuss how this incident constitutes abuse and neglect. The definition of abuse, according to the Human Rights Regulation, explicitly includes the use of more restrictive intensive services or denial of services to punish the person that is not consistent with his individualized services plan. Elizabeth should not have been placed in seclusion to begin with, as she was not engaging in behavior that placed herself or others at immediate harm. This use of more restrictive measures was enacted for the sole purpose of reprisal for disruptive behavior and was not consistent with her services plan, which detailed a history of trauma. The definition of neglect, according to the regulations, is the failure of a person, program, or facility responsible for providing services to do so, including nourishment, treatment, care, goods, or services necessary for the health, safety, and welfare of an individual. Part of the services that Western State provides is emergency management, specifically seclusion restraint for behavioral purposes. According to Western State's policy, seclusion restraint may only be used to prevent a patient from harming self or others. Western State's records clearly show that this is not why she was secluded, and that her behavior posed no immediate danger to self or others. Failing to follow proper protocols for seclusion is a failure of Western State's policies, a failure to meet clinical standards, and a failure to follow the human rights regulations. Therefore, Western State's improper use of seclusion here was not in compliance with the federal and state laws, regulations, and policies and professionally accepted standards of practice. This is a violation of the human rights regulations and constitutes abuse and neglect. Now we will discuss Western State's failure to conduct a full and impartial investigation consistent with the regulations. The BHDS policy requires that an investigator complete the written investigation report within 10 working days. At the conclusion of the investigation, the investigator must submit a signed and dated investigation summary report with all documentary evidence included. The regulations also outline these requirements. Western State simply failed to do this. They did not develop an actual investigation report and summary, which of course was never signed by the director because it didn't exist. These failures violate DBHDS's policy as well as the regulations. It is also abundantly clear that the investigation itself did not meet any reasonable guidelines for investigation practices. The entire investigation, by Western State's own admission and documentation, consisted of the investigator contacting Elizabeth's treatment team, the treatment team saying they had already spoken to Elizabeth's sister, the investigator taking the team's word that the incident was resolved, and that's it. The case was closed. No interview of Elizabeth, no interviews with staff, no review of records, and no review of security footage. The utter lack of an investigation is a clear failure by Western State to fully review the available evidence and to complete a comprehensive or even credible investigation. Western State also failed to comply with any of the timelines for the human rights complaint process as outlined in the regulations. Western State in their response has conceded that these were a process error, but let's call it what it is. This process error was a repeated violation of the human rights regulations. We ask that the LHRC uphold these admitted violations and additionally find that they failed to conduct an appropriate investigation. Now we'll discuss Western State's failure to follow sound therapeutic practice. For multiple instances within this event, its documentation and the subsequent investigation in which sound therapeutic practices, policies, and procedures were not followed. We have already detailed how Western State failed to appropriately document and investigate this incident. Furthermore, we've already explained our concerns as to Western State's failure to document the client's medical conditions and a history of trauma on her seclusion restraint contraindication form. Failing to appropriately explore contraindications placed Elizabeth at significant risk of re-traumatization and injury and grossly violated her rights. In addition to these documentation concerns, Western State violated the regulations by imposing a policy that they interpret to not allow for accommodations for clients with disabilities. Western State's seclusion restraint policy states that the seclusion rooms must be free of any potentially dangerous items or structural defects. It doesn't actually say you can't have a chair, and it doesn't actually say you can't have a mobility device, but the hospital has chosen to interpret their policy. The way they've done that at large has been discriminatory against individuals with disabilities, including Elizabeth. Very, very briefly, I want to discuss Western State's repeated use of Haldol as a PRN for Elizabeth, despite her guardian's concerns that this was not the best medication for her. We understand that determining what medication works best in a given situation is clearly a matter of clinical judgment. However, the treatment team's decision to continually re-educate Elizabeth and Marion on how those benefits, rather than trying another medication, is not in the spirit of person-centered care and should have been handled differently. Lastly, Elizabeth's sister and guardian, Marion Huber, would like to say a few words. Marion?
Yes, I want people to have an understanding of who my sister is, not that just she's this faceless person. She had a birthday on the 16th, and when she was asked how old she was, she said, "I'm 12 years old." She likes to talk about Pebbles and Bam Bams from the Flintstones show, and she's also a big fan of the cartoon character Scooby-Doo. That's Elizabeth's mental age. She's experienced so many serious traumas in her life, many of them recently. She survived a horrific fire at a group home in North Garden and narrowly escaped with her life. This information was in her record when she was accepted at Western State, although I had great difficulty meeting any responsible person on the phone when she was admitted. The hospital team also knew that she could not walk independently and needed the rollator to get anywhere. They should have read in her record that every part of her body ached from arthritis, and she's so nearsighted, she can't really see the features in your face unless she's a foot away from you. She hears a continuous stream of voices she can't control, and no combination of medications has been able to significantly reduce them. The pharmacist at Western State made an assessment of Elizabeth's medication history, and it will definitely support what I'm telling you there. The voices she hears are harassing her and causing her distress. She will often scream when she can't make them stop. She also screams when she's afraid or in pain or overwhelmed by the noise of public spaces, like what she experienced on the Oak Unit. Elizabeth wants very much to have comforting caregivers, folks who treat her with kindness. She wants to be hugged, teased like a kid, sing Amazing Grace and other songs. She's at her core a kind and loving person who can feel concern for others and wants to be accepted. If someone felt like she was a threat walking toward them, she may have just been trying to get someone to acknowledge her, and without getting close, she can't tell if anyone is actually listening to her. At 250 pounds and unsteady on her feet, she's more likely to fall over and hurt herself than be a real threat to anyone else. The fist shaking and table banging are gestures of frustration. Her pain at the hospital was constant: headaches, backaches, tooth pain, knee pain, and unrecognized constipation. She communicates in a kind of code that people have trouble deciphering. When caregivers or nurses can't understand her, she gets irritated and anxious, and the auditory hallucinations become more threatening. I've been with Elizabeth for many crises in her past decades. She has fumed and stomped and screamed, but she has never hurt me. To be put in a room where she could not leave even to go to the bathroom was likely a reminder of past traumas, like being locked in a bathroom with a peer who sexually assaulted her at a CBS day program in Norfolk, Virginia.
Miss H, that's the 15 minutes for your all's presentation.
Okay, thank you.
Thank you.
Thank you. Western State Hospital. Do the committee members have any questions on the statement or the testimony at this time?
No.
Okay. Western State Hospital, do you wish to take your 15-minute allotted time to present your case, ma'am?
Maynard, Dave had a question. You had your hand up, Dave?
Oh,
Yeah,
okay.
but I can hold it until all the testimony. I just, whenever it's appropriate. I couldn't,
Okay.
I wanted to make sure that this wasn't our time.
Okay. Yeah. Western State Hospital, do you wish to take your 15 minutes to
Yes,
present
please.
your case?
Yes, please.
Okay, your time starts now, ma'am.
Okay. Individual number one's complaint alleges that the facility incorrectly used seclusion and restraint. Per regulations, providers shall document in the individual service record all known contraindications to the use of seclusion, timeout, any form of physical or mechanical restraint, including medical contraindications and a history of trauma, and shall flag the record to alert and communicate this information to staff. This requirement was fulfilled via the completion of the BH intake assessment, please see Exhibit 5, This assessment is required for completion upon admission and contains presenting problems including history, medical problems, physical aggression, agitation, and anxiety. Additionally, a history of sexual abuse was documented. Additionally documented at admission, please see Exhibit 6, was individual one's worsening agitation, hallucinations, delusions, and disorganization. Her guardian is described as feeling ill-equipped to care for the patient as she is unpredictable. Individual one was reportedly sleeping poorly and screaming through the night. For behavioral risk assessment, notes a history of harm to others and harm to self, hitting self with objects when frustrated. Contraindications to seclusion and restraint are additionally a required entry for all facility admissions. The determination is made by licensed clinical staff upon consideration of all available information. This clinical decision is based upon individual consideration of diagnosis and patient history. It is not an automatic determination. To imply otherwise is to remove critical decision-making and care considerations of clinical staff. Additionally, the attending psychiatrist could have altered or added an order at any time during the client's hospitalization. The clinical decision was no contraindication to seclusion or restraint. See Exhibit 7. There is a vitally important distinction between the terms seclusion and open seclusion. Open seclusion is a misnomer as it is not technically seclusion at all. Rather, the client's physical location is in the unit's seclusion suite, the door is unlocked and open, and the client unrestrained. In this circumstance, first shift nursing documentation, Exhibit 8, noted this client was yelling out most of the day and had become verbally aggressive and approached staff as if she was going to hit. It is also noted she was not able to be redirected. Alternatives offered included Tylenol and or listening to Christmas music. She was unable to complete a dental appointment due to her level of agitation. In the afternoon, she was banging on the table in the day room, which is a risk for self-injury. She was escorted to her bedroom, but continued to yell. The staff of 2 managed this disruptive behavior all day with little progress or relief for this client. On second shift, nursing documentation reflected continued disruption to the milieu, yelling, shouting, verbal aggression, upsetting peers, and the inability to follow directions. The effect of constant disruption on the safety of the milieu for all clients in an acute mental health facility setting cannot be overstated. At 16:45, this client was escorted to the seclusion suite where the door remained unlocked. She was not in seclusion. The relocation, decrease in stimulation, and sparse appointment of the seclusion suite for 1 hour and 15 minutes was successful in mitigating number one's agitation. Although generally disallowed in this hospital space due to possible use as a weapon, she was allowed the use of her rollator to sit upon due to her health limitations. See Exhibit 9. There was no charted documentation regarding seclusion, order, notes, or assessments, as this was not a seclusion event. Redirection is a verbal tool used by staff in their attempts to de-escalate undesirable behavior, agitation, or aggression by patients, and is always in an effort to support the helping alliance and avoid the use of seclusion or restraint. When patients are described as non-redirectable, it is often a behavioral indicator and can be a precursor to increasing escalation or aggression. Patient and employee safety is paramount. Individual one's complaint alleges that the facility violated the dignity of this client via the improper use of seclusion. This allegation is unfounded as individual one was not secluded. The complaint alleges that the facility violated the human rights complaint process in the conduct of their investigation. The facility acknowledges a process error after the initial investigation. The PRC's investigation revealed the treatment team working closely to resolve concerns with the client's guardian on the same day the issue was presented. The matter was perceived as settled at the lowest possible point of resolution, as is always the goal. The facility was in error when they did not complete the subsequent documentation. Western State Hospital is developing an internal software application to electronically facilitate the documentation of patient complaints with a goal to improve management of timelines. We have redoubled our efforts to cope with the regulatory parameters in our active facility setting. The complaint additionally alleges that the facility did not follow sound therapeutic practice and policies and procedures. Western State documented appropriately in the patient record. The incident in review has been inappropriately characterized as seclusion by the petition. Clinical documentation was accurate and complete. Regarding the appropriate content of a patient medical record, this is governed by DBHDS Health Information Management Guidelines. Multiple documents cited by the petition, the debriefing form, the investigation report, and official investigation findings are necessarily not a part of the client medical record. These types of documents are maintained separately from the medical record. Regarding documentation of medical conditions in the comprehensive treatment plan, the single document is not designed to be all-inclusive. The entire medical record is available to the team for use when making clinical decisions when formulating the plan. Had the information alleged as missing from the CTP not been included in the medical record, the petition could not have alluded to it. Again, the determination of contraindications to seclusion and/or restraint is a clinical decision. It is clearly outside of the expertise and purview of the DLCV to attempt to dictate its appropriateness for this client. Similarly, the petition comments on facility policy for seclusion suite rooms to remain free of any potentially dangerous items or structural defects. This policy was developed for the safety of clients. The standard clinical interpretation of the facility to limit the room content is additionally not subject to the purview of the DLCV. In this instance, the facility made an exception for the comfort of this client and allowed use of her rollator for her short time in the suite location. The client's rights were not violated. Individual one's complaint alleges that the facility did not respect the authorized representative's preferences regarding medication. Individual one's guardian was actively involved in her care, as evidenced by multiple notations in the record. Please reference Exhibits 2 and 3. Upon admission, Ms. Huber verbally acknowledged medication consent, that's Western State 10 and Western State Exhibit 11, on 12/3 on behalf of her sister. The treatment team stayed in regular contact with the guardian, explaining their clinical medication decisions. At no point during the hospitalization did the guardian revoke this consent or specifically revoke consent for the use of Haldol. Additionally, the team obtained formal psychopharmacology consult. At the 12/8/20 psychiatrist weekly note reflects the guardian's positive response with this consult request. Please see Exhibit 12. That concludes our presentation.
Okay, we'll move on to closing statements. At this time, Ms. Huber, do you or your designee wish to use the 5 minutes allotted time for a closing statement?
Is this the last 5 minutes?
Yes.
Yes, ma'am.
Okay. All right, Virginia, it's yours.
Okay. All right. I want to close out our statements by making a few clarifications and explaining the corrective action that we are requesting. First of all, a history of hitting herself is not the same as an immediate risk of harm. A diagnosis is not the same as an immediate risk of harm. Non-compliance is not the same as an immediate risk of harm. We realize that this was a difficult situation for staff, but the way they handled it was a violation of the client's rights. In terms of evaluating whether it is appropriate for the client to be granted an accommodation for her disability, I would argue that the Disability Law Center of Virginia is an excellent authority on this topic. As much as Western State wants us to believe that this wasn't really seclusion, all of the available evidence suggests that it was. Director Smith herself said that it was seclusion when she wrote about it to Marion. You can say it wasn't seclusion until you're blue in the face, but the facts are clear. She didn't think she could leave the seclusion room, so it was seclusion. We asked multiple times to see the surveillance footage of this event so we could clearly see whether she was able to leave, but Western State wouldn't give it to us. So we have to use the documentary evidence, which all points to this being a use of seclusion. Also, and primarily as a point of clarification, Western State has alleged that criticizing their use of seclusion is outside of DLCV's purview. Western State's assertion that since DLCV are not clinicians, we cannot assess episodes of seclusion or the presence of contraindications as human rights violations is inappropriate and preposterous. They are trying to set up a precedent in which no one can challenge them on clear rights violations without a medical degree. By this logic, patients would never be able to make human rights complaints because they would have to defer to their clinicians. It would also mean the human rights advocates and most members of this LHRC could not make determinations in these cases as they are not all clinicians. Thank you once again to the members of the LHRC for hearing today's petition. The client and her guardian have truly been a pleasure to work with, and throughout this process, Marion has consistently said that her goal in lodging this complaint is to make sure that her sister and patients like her aren't harmed in the future. Western State isn't always in the best position to treat people like Elizabeth, clients with multiple disabilities, difficulty communicating, or who may need mobility devices. To that end, and to remedy the gross violations of your human rights, Elizabeth and her guardian request the following: that Western State revise all facility policies to ensure that they expressly allow for accommodations for people with disabilities, that Western State develop staff curriculum in collaboration with the local REACH program to better educate Western State staff on de-escalating patients with developmental disabilities, and that Western State train all staff, that Western State develop an appropriate sensory room for patients with enhanced sensory needs, Western State and DBHDS at large prohibit the use of seclusion for individuals with developmental disabilities and commit to reducing this use of seclusion for patients by at least 50% within the next year. That Western State retrain staff on the use of seclusion and restraint, identifying pain in individuals with communication difficulties, and providing appropriate accommodations. That Western State develop a policy requiring individuals with developmental disabilities receive sensory and communication and occupational therapy assessments within 1 week of admission, and that Western State review their internal policies and practices surrounding the evaluation of contraindications to seclusion and restraint for newly admitted patients. Thank you so much for your time.
Thank you. And Western State Hospital, would you like to use your 5 minutes allotted time for your closing statement?
Yes, please.
Your time begins now.
Thank you. Informationally, sometimes identical or duplicate complaints are submitted via several different oversight or regulatory agencies. It has been a challenge to manage the separate process requirements and due dates in a facility of our size and scope, and given our resource limitations. That said, Western State is actively working toward more efficiently and functionally managing the process components of addressing patient complaints. We are on the cusp of rolling out an internal software tool designed to more efficiently track and alert responsible staff of pending due dates. In the case of this complaint, the process was compliant, but the documentation was not. Additionally, the facility has resolved to employ the use of certified mail when indicated to assure and confirm timely off-site delivery of correspondences. The petition mischaracterized open seclusion. The reality of the event does not meet the code definition. Any client in open seclusion is encouraged to remain in the location, but is not physically restrained. The door is not shut nor locked. The client has access to walk around in the suite to the restroom, and if they choose to leave, they are not barred by staff. Western State did not seclude this client. Therefore, the patient record does not reflect seclusion documentation. Multiple members of the Western State treatment team remained in regular contact with individual number one's guardian regarding her care, treatment, and recommended medication regimen. Members of the treatment team are present to answer your questions. Thank you for your consideration. The facility will await the findings and recommendations of the LHRC with specific regard to this complaint.
Thank you, Gail. At this time, does the committee members have any questions of Western State Hospital or to the petitioner? Dr. Polk?
Yes, I do. Just Ms. Huger, if I could, there's a report of this WSH Exhibit 1, and there's 3 dates on it. I'm sorry, it says investigation final was 12/11, then the next page says 4/27, other rationale. It said that you suggested use of seclusion instead of medications when she was acting out. You want your sister to have use of a chair while in seclusion. And this is the person, I'm assuming this is Brandon Rotenberry, I don't know, said this is against hospital policy, was explained to you as an accommodation. They did allow your sister to sit on a rollator while in seclusion. Is that what you remember them saying to you?
There were multiple conversations with multiple people. My first conversation was actually with the nurses on the unit after it happened to try to determine what actually occurred. And originally, I thought, well, it made sense for Elizabeth to be secluded in her room. But they said that wasn't allowable. That's a comfortable place. It has a bed. But they said her screaming could be heard because her bedroom was close to the open space where people congregate. So she wasn't allowed that comfort. If the one that doesn't have the options that you think they do, there was lots of Haldol given orally that day. There was always the threat that she would have an injection and get a higher and higher dose to the point where she becomes almost comatose. And I know that the medical staff is limited there. It really requires intensive monitoring if you're going to actually make that person unconscious.
Yes, ma'am. Ms. Huber, thank you. I was just referring specifically to where the team explained that she couldn't have her rollator while in seclusion. And I see a follow-up letter on February 19th from Mary Claire Smith, who states, hospital policy prohibits any type of furniture to be in a seclusion room, quote unquote, and she was allowed to sit on a rollator while in seclusion. I have a question for Western State, if I could, either Dr. Anderson, who was the original letter here, or whoever. I'm sorry, I didn't catch your name. It just says WSH, who was speaking for WSH. If the patient wasn't in seclusion, then why was it charted at least 2 places that I can see, and then even another where Dr. Smith said, while in seclusion, she may do this while in seclusion. And if indeed it wasn't seclusion, as you state, then why couldn't she have a chair? Because it's not seclusion. By your definition, you said you can't have chairs or things that can harm someone in seclusion, but yet she wasn't in seclusion, but she was placed on she was allowed to sit on a rollator. If it wasn't seclusion, then why not allow her to sit comfortably? I'm trying to understand. It is documented in 2 or 3 places where the nurses said in seclusion. I think one of them said open seclusion. And if it's not, is that the process error that you're speaking of? Or is that just, I'm trying to understand why it was stated several times, including the February 19th letter. And she refers to in seclusion room and then while in seclusion. And I took that to mean it meant seclusion. And if it's not, I'd like, where's it, where we're, I don't understand. Perhaps we'd come up with something that could define that better. I'm sorry for that long question, but why say seclusion and then why not give her something if it wasn't seclusion to sit in, if it really indeed wasn't seclusion? Sorry, it's a long question.
Dale?
Yes.
I don't know who
I
was
think he was
speaking.
asking you the question, Gail.
Or Dr. Anderson, so I wasn't sure who was supposed
Either
to
one.
reply.
Yeah, that'll be fine, Gail. Thank you.
Well, I would just say that I think that the policy speaks to having things in the seclusion room. So if there's any confusion, it may have been that that they were talking about the seclusion room, which is where she was in what we call open seclusion. So I don't know if that's what led to the confusion about it, but and I can't speak for Dr. Smith in her letter if that's what she meant, but that's what I think might be going on.
I have a question for Dr. Anderson. If it stated in the chart that she was in her room, the staff attempted to put her in her bedroom before the seclusion room. Is that charted as to how long her stay in her bedroom was?
I don't know. I'd have to look. I think at some point a decision was made that her behavior in her room was so disruptive to the rest of the milieu, at some level, that removing her to a less stimulatory area for both the milieu and herself was what they decided to do. But I don't know how long it was. It could have been for a while, but I don't know if the record reflects that or not.
It says 1645, Renee, on the letter that
That was
Dr.
when she entered the
to the
seclusion, non-seclusion room, but how long was she in her bedroom before that was my question.
Yeah.
I don't think the documentation reflects how long she was in there. I mean, we could look back at when at the time the notes were written, but that wouldn't necessarily reflect the proper amount of time.
I had a question for Western State as well. David preempted my question on the chair, which I have the same question as to why was the concern over the furniture in the room if it was not being truly used for seclusion. One question would be, were there any other alternatives in the building, dining hall, or other facility where she could have been isolated as opposed to being put in the seclusion room where her noise would not have disturbed the others in the facility? That's one question. The second one, both to Western State, you'd mentioned she was encouraged not to leave the room. This is a person with IDDD. What form, if you tell a person, sit here, don't leave, that's not encouraging. I was wondering what the parameter for encouraging was as you all have described it.
Could you repeat the last question for me?
Yeah, basically the encouragement, as you mentioned that she was encouraged to remain in that room, looking at the regulation, which says specifically that seclusion can be conferred by verbal restraints. What was, can you describe the type of language that might have been used to tell her not to leave that room? As a practical matter, I imagine somebody taking somebody and sitting down and said, you stay here till I come back, or you stay here till we let you out, or something. But you mentioned it was encouraged instead of instructed. I was just trying to ascertain what the difference was, or how you might have instructed her or encouraged her to stay in that room verbally.
The presentation was designed to describe the practice of open seclusion here and the circumstance. It was not specifically to describe that particular instance with that person. We can't really speak to what was said to her if it's not specifically documented, we don't know, but it is our practice in open seclusion to move a client or escort a client to a less stimulatory area and more sparse appointment, and it is often successful in actually mitigating the actual use of seclusion or restraint. It's used in place of.
The other question was on the regarding other locales in the facility that might have been used to provide less stimulation or simply to isolate from the general population. Were there no other alternatives?
Okay, I can answer that. The dining room that you suggested is an open glass room, which is directly in front of the milieu, so stimulation will be high there. And that seclusion suite was designed to accommodate this kind of therapeutic condition, to take that client away from open stimulation directly from other clients and have them to calm down in an area designed for such.
Okay. That's all I have at the moment.
Okay.
Okay, are there any other questions by the committee members of either party?
Just one more, if I could, Maynard. I just want to, it's just throughout all the correspondence, all throughout, it just says while in seclusion. And I think that's what's getting me, is that we're saying up front, that's not seclusion. I see open seclusion, I think twice, maybe one more time. The rest of the time, people just kind of refer to it as seclusion. And you know, we don't always have official names, but everybody's had rooms or things we did in medicine, and we all kind of knew what they meant. And that just seems so familiar. We keep using the term seclusion. And if we're actually secluding her, I mean, even if, I mean, I just don't get the distinction, because it seems to me like, yeah, she was in trouble, and you, in my mind, removed her from the problem that she was having, and I believe in an attempt to help. But I could see where you might be confused as to what is happening to your loved one, or yourself if you're that person. Because it's just, it's not clear to me, and I haven't been able to make it clear. If you can clarify that, that's great, but I can't make it clear in what you've sent in the documentation. Thank you.
Well, I can't speak to the comments in the documentation that say it, but there is a marked difference between being in seclusion, which is being in a locked room alone, isolated, and being in a suite area that's open, that has a bathroom access, open door with a staff there to encourage, distract, try to calm down a client. And so it is an important distinction. And I think what we're trying to say is that however it may have been mischaracterized at several points in the chart, that it was what, and it's probably a bad term, open seclusion, because it includes that word, which probably leads to the problem. But in this case, it was clearly not what we would say is seclusion, which is a locked door, being barred from leaving an area verbally or physically.
Okay, thank you, Dr. Anderson. If there are no further questions for either party, this will conclude the end of the hearing. The LHRC will go into executive closed session for deliberation concerning the petition heard today. The committee intends to deliver its findings to each party within 10 working days of this hearing, which would be July the 5th, 2021. Each party has a right to appeal an adverse decision. to the State Human Rights Committee, should they desire to do so. At this time, with the exception of the LHRC, I would like to thank everybody for their time and their attendance. And I would like to ask everybody to go ahead and remove yourselves from the room.
Richie,
Sir?
really quick, you still have to do the extension request for the LHRC to vote on that in open session.
That's right.
Sorry.
There was an extension request made by DLCV on behalf of the petition in order to gather information that they needed to present their case. And so what we need to do is go ahead, and there is a motion on the floor for that, for the committee to go ahead and vote on that for the approval or not. Renee?
So the motion's been set. Does anybody second?
I'll second.
Okay.
All in favor?
Aye.
Aye. Any opposed? We
Okay.
approve the motion.
Thank you, Renee. Anything else, Brandon? Did I miss it?
No, sorry, I just want to make sure we did that before.
Yes, appreciate you catching me up on that. Okay, at this time, like I said, we're going to go ahead and end the hearing. And if you're not an LHRC member, please excuse yourself from the room so the LHRC can go into deliberation and determine whether or not there were any violations to these regulations. Thank you very much for your time.
So who's Carlton?
Motion to move to closed session.
Open session.
Call for a
Open
motion
session,
to
I'm sorry.
return to open session.
I'll
So
move that we
Teresa
return to open
motions.
session.
All in favor?
Aye.
Aye. Any opposed? No.
Okay. The local human rights committee certifies that only public business matters lawfully exempted from statutory open meeting requirements and only public business matters identified in the motion to convene the closed session were discussed in closed session. Each LHRC member must individually say, "I so certify."
I so certify.
I so certify.
I so certify.
I so certify.
Okay. And with that, do you want to go ahead and try to reschedule another meeting to where we can make a decision on these other human rights regulation violations?
So
And
can
what
we
will work
send
best
out
for
a few
everyone?
dates and times in an email and we can respond that way to get it done before the July 5th due date?
Okay. I mean, I can send you, I can send you some dates. And hopefully, like I said, it's up to you. I work around you. So just let me know. I'll send you a couple of dates and y'all just let me know if you're good with it.
Yeah, I'm pretty open. I've got a couple of meetings and stuff, but nothing too bad the next week.
Yeah.
And I'd like to do it sooner rather than later, so it's fresh in our memory. And
Absolutely.
Yes.
Absolutely. I would actually like to try to get it done this week.
Okay.
I'm open to
Okay.
tomorrow and Wednesday.
I can be very flexible this week, Maynard. So anytime this week, let me know.
Okay. Will
All right.
do.
Thank you, guys.
All right. Thank you.
Thank you, Brandon.
Thank you. Do you want to adjourn us, Renee?
Motion to adjourn.
Motion to adjourn.
Second.
All right. All in favor?
All in
Aye.
favor. Click on the
Thank
leave
you.
button. Yeah.
Thank you.
Mhm.
Bye.
Bye.